Good afternoon, everybody. Um,
Good afternoon, Charlene.
I don't
How
know if
are
I can.
you in
I'm
Durban?
good, thanks. The weather is awful. It suddenly changed and it's quite windy and rainy outside. So we just struggle to get home in time for this. And yeah. So
Winter has started in Cape Town too, today.
yeah.
So,
We ex
forward
we've
to
got
this.
a level 4 weather alert warning. So I think it's going to be a bit of a bad storm.
Sure.
So anyway, I think I'm going to start, Estelle. Um,
Right.
so good afternoon, everybody. Those who don't know me, I'm Charlene Parasnath. I'm the head clinical unit of hematology, clinical hematology at Albert Lutuli in Durban. And I would like to actually thank the Blood SA team for giving us the opportunity today to present. But before we do so, there's a few housekeeping rules which we need to go through. So for those of you who may be new to this platform, these recordings are actually found on the Blood SA website under resources, a deep dive. So if you are um, uh, looking to listen to some of the previous talks, please go onto the website and access them there. Um, this is an interactive session, so please do place your comments or questions in the chat box, and we will attempt to answer them maybe after each talk or perhaps at the end of the talk. Um, if you are not on the mailing list for this meeting, please uh, email Melanie Davids at UCT, and she will actually add you on so that you can be aware of the meetings that come up in the future. CPD points will be automatically submitted to the HPCSA for each attendee from South Africa. So please ensure that you're attending with your own registered Zoom account and not in a group. For any CPD queries, or if you need a CPD certificate for another country, please contact Melanie Davids, and her email address is up on the screen. And 1 hour attendance is required to qualify for a CPD point. Blood SA and the speakers value your honest feedback, so please complete the anonymous feedback survey at the end of the Zoom meeting. And it is anonymous, so we are unable to respond to requests requiring response made in that section. So let me move on to the next slide. So this is the Blood SA management team. The deep dive leader is Prof. Estelle Verburg. National Trading Coordinators Gerdien Gritzinger. CPD Administrators Melanie Davids, and National Coordinators Bridget McMillan. And I think on behalf of everyone of the academic fraternity in South Africa, we'd like to thank Prof. Verburg and a team for hosting this platform and for the wonderful content that we are exposed to every week. And it really does add to our knowledge base, and we are grateful for this. Um, so, I'll move on to our session for today. So we have 3 speakers. I think I will introduce everyone at the beginning so that we can have a good flow of the meeting as we proceed. So we have our session in 3 parts. So we have 2 clinical cases. Thereafter, a little discussion on the lab diagnosis of plasma cell leukemia. Sorry, we are talking about plasma cell leukemia this week. And thereafter followed by an overview and update on treatment. So the first speaker is actually one of our medical officers who's been with me for 4 years, Dr. Tennille Abrams, and she is a really hardworking, dedicated doctor. She's young, but she's actually learned so much so quickly, and she's an integral part of our team. And her passion is actually hematology, and she's got a lot of experience now in our transplant unit, and she's hoping to pursue a career in hematopathology and then clinical hematology. Our next speaker is, sorry, let me just move on. Okay, is Dr. Rita Govender. So Rita is actually one of my mentors. When I joined as a hempath registrar in 2002, I worked with Rita for a while before she left to go into uh, to Sanbis. And so Rita is also a clinical hematologist, and she has a wealth of experience, and she's just a wonderful person to um, bump things off, and she's actually always willing to help and teach. And she's recently completed her blood patient management course, and so she's really looking forward to collaborating with others who are like-minded. And so Rita, her full-time job currently is that she's a pathologist at AMPAC, and so Rita will be giving us a insight into the lab diagnosis of plasma cell leukemia. And then finally, Dr. Yadia Miraj, she is our fellow at Albert Lutuli Hospital. She's in her last stretch of her training with us. She joined on the Satchis BMS Foundation grant, and she's really developed very well, and I'm really proud of her accomplishments in the past 2 years. And I'm wishing her all the best for her exams coming up. And Yadia also is a hematopathologist. She qualified from Stellenbosch, and she did her MMed in CLL, and she's now preparing for exams. So without further ado, I think I'll hand over to Tennille, who will talk us through two of the cases that we've treated in our unit. Thank you. Hey, Tennille, I can see your screen. Hi, Tennille. Sorry, I'm just thinking, can anybody, is it only me, or can anyone hear Tennille?
No, we can't hear anything yet.
I think you may be muted.
No audio as well from my side, Charlene.
Danielle's unmuted, but it doesn't seem to be coming through the audio.
Okay, let me call her. Hello, Tennille's having a bit of trouble. I've asked her to sign off and sign on again, and let me just give her 2 minutes. Um, okay. Rita, will you be able to start? I'm going to share, I'm going to get Tennille's talk, and I will have to share, and she will join in from her phone. Can you start? Thanks, Rita. We're seeing your screen. You can go ahead. Hi, Rita, are you there?
Hi, I'm here.
Okay.
Did
You can
everyone
go.
get my intro?
No. Can you go again, please?
Can I go again? Okay, all right.
Yes,
Sorry for
please.
that. Okay, so good afternoon, everyone, and thank you very much to the organizing team for the absolute privilege of participating on this platform. I was tasked with offering some laboratory perspectives on primary plasma cell leukemia. And so I started off with, looking at the diagnostic criteria across the three classification systems that are currently in use. And with WHO HEME4R and HEME5, they are very clear in defining this entity as a clinical variant or subtype of plasma cell myeloma with circulating plasma cells. With ICC 2022, I was somewhat puzzled. There was no explicit mention of it in the classification system. So I elected to contact a friend I found two really good review articles on ICC 2022 classification, and I contacted one of the co-authors of this publication, Prof. Pikaluga, and his response returned as ICC didn't even mention it, so we can assume it's considered a variant or subtype of multiple myeloma. And in this paper, Plasma Cell Neoplasms and Related Entities, Professor Cook concurred with that sentiment and went on to say further that nothing has changed according to International Myeloma Working Group criteria, and it aligns with what WHO is also presenting, right? So ICC 2022 has stopped at a genetic classification of myeloma. And then we know that the first condition of diagnosis is to meet criteria for multiple myeloma, which remains rooted in the International Myeloma Working Group consensus of 2014. And the starting point is that of clonal plasma cells of at least 10% on the marrow, or a biopsy-proven bony or extramedullary plasmacytoma that's attended by any one or more of myeloma-defining events. And these myeloma-defining events are typified by the CRAB criteria, which basically describes end organ damage that can be attributed to the underlying plasma cell proliferative disorder. And then we have also the biological markers, which goes by the acronym of SLIM, describing the 60% or greater clonal plasma cells, the free light chain ratio, and MRI-defined bony lesions. So any of these biomarkers are sufficient for diagnosis, regardless of whether the CRAB criteria are present or not. And on the basis that they have been shown in 2 or more independent studies to be associated with approximately 80% or higher risk of developing myeloma end organ damage within 2 years. So we can see that both cases clearly meet criteria for myeloma. Then we come to the second condition of diagnosis, which refers to the circulating plasma cells. So case 1, 38% plasmacytoid cells reported on peripheral smear, and case 2 had 7% plasma cells. So, you know, the second component of circulating plasma cells has evolved over time, and I'm going to just go into the, I'm just going to trace the evolution of this requirement. So way back in 1974, Kyle stipulated that circulating plasma cells should be at least 20% and an absolute count of at least 2 × 10⁹ per liter. But many series considered, you know, one of the 2 criteria sufficient for diagnosis of plasma cell leukemia. Then in 2014, almost 4 decades later, the International Myeloma Working Group concurs that the criteria are too restrictive. And the following consensus was put forth that careful examination of peripheral blood by conventional microscopy be undertaken in all patients with multiple myeloma, and that involves 100 to 200 cell differential count. Continue to establish the diagnosis by the present criteria of at least 20% circulating cells and or absolute count of 2 × 10⁹ per liter. And in the interim, continue to record all lower counts of at least 5% or more, or an absolute count of 0.5 × 10⁹ per liter. So this would permit review of the diagnostic criteria and allow prospective analysis of the biology and clinical course. And hence we see WHO HEAN 4R in 2016 stipulating at least 20% or more circulating cells, or an absolute count. So one could use the either or the other criteria. Then in 2021, the International Myeloma Working Group offered new perspectives on circulating plasma cells, and stating that the percentage of plasma cells is a continuous variable. There's no scientific rationale to establish the appropriate number of circulating plasma cells to achieve the diagnosis of plasma cell leukemia, and the percentage is to be obtained from clinical evidence. So they used two retrospective series that focused on overall survival as a basis for decision-making, whilst accepting that there were limitations in these two studies. So the Spanish cohort at 100 patients and the Mayo Clinic cohort at 176 patients. So the conclusion was that there was consistent finding of reduced overall survival in patients with 5% or more circulating plasma cells, as compared to patients with myeloma having no circulating cells. And the proposal was that all patients diagnosed with symptomatic myeloma and at least 5% circulating plasma cells by morphology of peripheral smear should be considered as primary plasma cell leukemia. And we should note that this change in criteria does not apply to secondary plasma cell leukemia. And in fact, in any patient, circulating plasma cell biomorphology is considered a marker for highly proliferative and aggressive disease. And thus, we have the current status quo where WHO HEM5 and ICC 2022 using 5% or more circulating plasma cells as the second prerequisite for diagnosing plasma cell leukemia. So the implications of the new 5% diagnostic threshold is that we could conceivably see an expansion in patient numbers, and this may permit a better definition of this entity according to clinical features and the different modalities that we use in diagnosis. And hopefully this will shape a more optimal management approach. So, just to take that concept of circulating plasma cells to a deeper level, there's been a number of groups that have been involved in quite intense activity, looking at circulating plasma cells by multiparametric flow cytometry. And this is an attempt to try and risk stratify multiple myeloma. And although we have, fairly interesting data emerging from these studies, as yet, there is no consensus on cutoffs. So I found this study by Jelinek et al. Particularly interesting. And they looked at a cohort of 395 patients with transplant-ineligible multiple myeloma, and were able to define an ultra-high-risk group of patients having 2 to 20% circulating plasma cells by flow cytometry that showed an outcome that was very similar to real-world cohort of patients with primary plasma cell leukemia. And hence they put forth the proposal that we use a 2% circulating plasma cell threshold that is elicited by flow cytometry as opposed to morphology as biomarker of a hidden primary plasma cell leukemia. And it's to be included in the diagnostic workup of multiple myeloma. So let's look at immunophenotyping for primary plasma cell leukemia, and I'll start with some basics on the Euroflow panels. So we have the backbone markers of CD38, 138, 45, and 19. And these markers are found in both tubes and would help us to distinguish between normal, reactive, and clonal populations of plasma cells. The additional markers will, specify aberrancies as well as help us to determine clonality. So we've got a panel basically incorporating 12 markers. So normal plasma cells, they are usually positive for CD45, 19, 81, and 27 with a normal kappa lambda ratio. Abnormal phenotypes in plasma cells include loss of CD45, CD19, and CD81, aberrant gain of CD56, 117, and CD28. And we should also bear in mind that an abnormal phenotype on its own does not necessarily mean the cells are clonal. For this, we need to show monotypic cytoplasmic light chain expression. So plasma cell leukemia, when compared to multiple myeloma, tends to show more frequent expression of CD20, 23, 28, 44, and CD45. And there's less frequent expression of CD9, 56, 71, 117, and the HLA-DR antigens. So, so the only comment that I can offer in terms of the immunophenotyping on both the clinical cases was that both were CD5 negative. And Tennille, I'm sorry about this, but there's this is a spoiler alert. So both were CD5 negative, and no skeletal lesions were identified in both patients. And we know that CD5 negativity, it does associate with lack of skeletal lesions and also increase in circulating plasma cells. So that would be how the CD56 negative expression was is informative in these cases, in these two cases. So with regards to genetics of primary plasma cell leukemia, results are quite variable, retrospective, and in this particular table, presented by the working group in 2013, these results are unsorted, right? We can see that hypodiploidy, complex karyotype, deletion of 13q14 or monosomy, as well as deletion of 17p13, all feature quite prominently. And in myeloma, these are generally our poor risk genetics. Surprisingly, we see a fairly high preponderance of T1114 translocation as well, which in myeloma is associated with a favorable prognosis. And one can only postulate that perhaps there are other undefined risk factors that are overriding this favorable translocation. So both patients were subjected to fish studies, and there were multiple abnormalities elicited, and one can query whether these were hyper-diploid clones, but karyotyping and specific probes, structural probes for the fish are lacking. So we can't say it with a measure of confidence, but we can query as to whether these are hyper-diploid clones. So in the next couple of slides, I'm going to round off my segment with morphology aspects, starting with the normal plasma cell. And this is a cell that varies in size from 14 to 20 micrometers. It's round to ovoid, containing an abundant blue cytoplasm, usually packed with endoplasmic reticulum. there's a pale perinuclear area that corresponds to the Golgi apparatus, which we call the HOF. And we have a round, eccentrically placed nucleus with coarse chromatin, usually arranged in a clock face or art wheel pattern. And in the normal bone marrow, plasma cells will account for less than 5%, showing mainly an interstitial distribution and occasionally in small clusters. So changes that one can see in reactive plasma cells, Russell bodies, and then great cells. So this essentially is a Russell body. As I just said now, that the cytoplasm is really packed with endoplasmic reticulum. And then in conditions of increased immunoglobulin synthesis, one can get dilation of the endoplasmic reticulum manifesting as a Russell body. And then when you have multiple Russell bodies, you've got a morula or a grape cell. The Ducher body is a pseudonuclear inclusion. We see them here, two clear. And it's dilated endoplasmic reticulum that invaginates into the nucleus and creating the appearance of intranuclear inclusion. And these are specific to neoplastic plasma cells. So WHO describes 4 morphological variants of neoplastic plasma cells. The small cell variant, which basically has a lymphoplasmacytic appearance. These cells can also express strong CD20 and or cyclin D1 and commonly associates with the translocation 1114. And this was indeed the description from case 1, peripheral smear, which highlighted plasmacytoid forms and mature plasma cells. Then we have the mature form, which looks very much like normal mature plasma cells. And that seemed to be the morphology described in case 2. Then we have the entity of plasmablastic myeloma, with cells showing dispersed chromatin, tendency to prominent nucleoli, and they generally have quite a high nucleoplasmic ratio and HOF not so conspicuous. These cells may actually mimic acute leukemia. The 4th variant described is that of anaplastic myeloma. Cells are large, very pleomorphic, multinucleated, multilobated, and the differential diagnosis for this will include an anaplastic carcinoma, especially if it's attended by fibrosis of the marrow, anaplastic large B-cell lymphoma, and a plasmablastic lymphoma. And that's actually not the end of the story, because I then stumbled across this very interesting review, The Many Faces of Plasma Cell Neoplasms. And it brought, it's a paper that's originating from the MD Anderson Cancer Center, and it chronicles the creativity of plasma cells in morphological expression. So they have reported a monocytoid variant, a pronormoblast variant, a megakaryocytoid variant, signet ring cell variant, and a cleaved cell variant. And it occurred to me that here indeed is the quintessential shapeshifter of the hematology universe. I mean, the mantle cell just pales in comparison. And in fact, the plasma cell may on occasion also mimic several aspects of the mantle cell. And coming to the bone marrow assessment, one can have different patterns of infiltration, especially in myeloma. You would see interstitial microclusters of less than 10 cells, nodules, but sheet-like involvement tends to be more common with plasma cell leukemia, right? the marrow tends to be to show quite heavy tumor burden. And then some of the useful stains would be CD38, 138, and a MUM1 to semi-quantitatively assess the burden. And then light chain expression is preferably done by in situ hybridization as opposed to immunochemistry, where there's quite a lot of background uptake and can lead to quite a messy look to the slides. So in rounding up, I would say the morphology report for plasma cell neoplasm should include a careful assessment of the peripheral smear, undertaking 100 to 200 cell count. And if you have low numbers of circulating cells, especially in the setting of HIV, autoimmune conditions, active infection, to please consider peripheral blood flow cytometry, so to confirm clonality of the circulating population and to avoid condemning the patient to a grim diagnosis. Then assess your percentage of plasma cells on the aspirate and the trephine, and you would report the higher count, right? Plasma cell disorders by nature are prone to spatial heterogeneity or uneven distribution in the marrow. Describe the morphology of cells completely, as certain types of cells, certain types of morphologies may associate with certain clinical behavior. Outline the staining profiles that you've undertaken. Comment also on relevant stromal changes, which will include presence or absence of amyloid and fibrosis. What is the condition of the trabeculae? And any myeloma defining events that will help to finalize the diagnosis. Thank you for your attention. I'm happy to take questions either now or at the end of the session.
Thank you so much, Rita. I think due to the fact that we started late, I think we'll move on to Tennille's cases to catch up, and then maybe we can leave some time at the after Yavia's talk. But thank you so much.
Thank you.
Tennille, can you test your sound, please? We are not hearing. Okay, all right. Tennille, we're getting an echo in the back.
So sorry about that, everyone. I promise I'm not that technologically challenged.
Okay, Tennille, we can hear you. You can go ahead. We know you're not technically challenged. Okay.
We blame the weather. So I'm just going to talk about the case mainly and not so much the morphology, as Dr. Govender covered a lot of it. So the first case we have is a 32-year-old gravid female that was referred to us in September 2017 by the nephrology unit, and she was co-managed by high-risk obstetrics. At the time, she was a newly diagnosed RVD positive and was recently initiated about 1 month prior on a tenofovir-based regimen. Her baseline viral load was 4,848 with a CD4 of 149. As mentioned, she was at 12 weeks gestation and she was transferred to our institution as she had an acute kidney injury requiring dialysis. She was also septic in DIC, in cardiogenic shock requiring inotropic supports, and had a bicytopenia. She presented to a base hospital a few days prior with active bleeding and signs and symptoms of anemia, as well as lower limb swelling, but no other known comorbidities or significant social history. Due to her ill state, she was seen in our high care units, where she was noted to be confused and pyrexial with a temperature of 37.8 and a tachycardia of 100, saturating well on room air. She was on Dobitrex at the time with a BP of 134/56. She had significant pallor, with bilateral lower limb pitting edema. Her chest was clear. She was not in CCF, but she did have an ejection systolic murmur at the left sternal border, which could have been due to the profound anemia. Her abdominal examination found no significant findings, and she had no focal deficit despite her GCS being 14 out of 15. Baseline FBC was done and confirmed that she had a normocytic normochromic anemia of 4.6 grams per deciliter, with a moderate thrombocytopenia of 57 and a white cell count of 23.54. She was noted to have a left shift with 5% blasts on smear. Chemistry was done and confirmed that she had end-stage renal disease with an eGFR of 5. A urea was 42.4 with a creatinine of 42,294, which was complicated by a metabolic acidosis and hyperkalemia, as well as a hypercalcemia with a corrected calcium of 3.57. And as mentioned, she was septic with a PCT of 1.14. So this was the smear that was done on the patients. And as you can see, a proteinaceous gray appearance with binucleate plasma cells and marked rouleau formation. A bone marrow aspirates and trephine was done, and it was hypercellular and showed diffuse infiltration with plasma cells. You can appreciate some of the binucleate forms, and a lambda light chain restriction was noted. As Dr. Govender mentioned, she had a positive CD38, CD45, CD138, and a confirmed lambda light chain restriction on flow cytometry. Additional investigations on abdominal ultrasound, bilateral kidneys were noted to be echogenic with poor cortical medullary differentiation. She had a good ejection fraction of 68%, and due to her ill health, only a partial skeletal survey was done, but it showed no lytic lesions. Serum-free light chains were also done and showed that she had a free lambda of 3,000 with a reduced kappa lambda ratio of 0.01. Serum protein electrophoresis was done and showed a restricted band on the beta region measuring 8.2 and a restricted band in the early gamma region. Benz-Jones protein was positive with an IgA lambda on urine immunofixation. She had a normal female karyotype and no high-risk cytogenetics as mentioned by Dr. Govender. So in summary, this was a 32-year-old gravid female with the overall poor performance status at diagnosis. She had plasma cell dyscrasia meeting the criteria for primary cell plasma cell leukemia, which was complicated by anemia, thrombocytopenia, and renal impairment requiring dialysis. So as we know, plasma cell leukemia overall has a poor outcome, but factors impacting her overall survival were raised creatinine, low hemoglobin, low platelets, but she had no high-risk cytogenetics, lytic lesions, or extramedullary disease. She was RBD positive, virologically unsuppressed, with a possible HIV-associated nephropathy or tenofovir-induced toxicity exacerbating her renal impairments. She also presented in shock, which was in sepsis, which was complicated by shock in DIC, and she required high care support. So in terms of her supportive management, she received blood transfusions, platelets, and FDPs. Sepsis was treated and she was successfully weaned off her inotropes. She continued to receive hemodialysis, and the decision made by obstetrics was to terminate her pregnancy due to a poor maternal state. She was given a stat dose of Zamita and started on dexamethasone on day 1 to 4 and later on day 12 to 15. Once she stabilized, she was transferred out of high care into our units, where she received 2 cycles of infusional CVAD while simultaneously receiving 3 weekly dialysis, and was moved on to renal-friendly ARVs, where viral load improved to 708. Unfortunately, at the time, motivation for thalidomide and bortezomib was declined, but we did apply through a donation program for the use of ixazomib, which was made available for her. She was discharged from our units around day 82, and a restaging bone marrow showed 1.7% MRD. She went on to receive 8 cycles of ixazomib, cyclophosphamide, and dex in our clinic. Throughout that time, a renal biopsy was attempted to determine the actual underlying cause of a chronic kidney disease, but that was unsuccessful. So she continued with 3 weekly dialysis and EPO. She became virologically suppressed with good control of her HIV, but a restaging marrow after the completion of these 8 cycles confirmed decreased disease progression, with 6% MRD. Following a MDT, the decision was made for her to attempt an autologous stem cell transplant. So she was mobilized with high-dose etoposide and GCSF. Unfortunately, she was admitted with a pathological fracture as well as moth-eaten lesions in her humerus, where she was seen by orthopedics and a collar and cuff was applied. Around day 8 of mobilization, she developed new onset seizures and her GCS dropped to 10 out of 15, where a CT scan confirmed that she had an acute subdural hematoma with mass effects. Following review by neurology and neurosurgery, it was deemed that she required urgent decompression by craniotomy, but due to her poor overall state at the time, she was only going to be for surgery if she qualified for an ICU bed. Unfortunately, following ICU assessment, her SOFA score, which is the sequential organ failure assessment, was 89%, making her a poor candidate for ICU, and she sadly demised on day 10 of her mobilization. Our second case is a 44-year-old female that was referred from neurology. She was RVD positive, virologically suppressed, also known with hypertension, but controlled with no target organ damage. She had a bicytopenia with an HB of 5.6 grams per deciliter and platelets of 120 times 10 to the power 9. She presented to base with progressive loss of vision, which was associated with headaches and tinnitus, and found to have grade 5 papilledema and hemorrhages on fundoscopy. The initial differential diagnosis was that of idiopathic intracranial hypertension. Post-medical history revealed that she had PTB about 10 years earlier, but completed 6 months therapy with no other known comorbidities. On examination, she was noted to be pale, but no other evidence of bleeding. She did have a tachycardia of 100, but all other vitals were in normal range. Her chest was clear. She was not in heart failure, but she did have an ejection systolic murmur at the left sternal border, which was possibly in keeping with her anemia. Her abdomen was soft with no masses or organomegaly. GCS was waxing and waning between 14 to 15, but she had no focal deficits. However, her pupils were sluggish to light, but reactive. Fundoscopy confirmed that she had pale retina with bilateral papilledema. The discs were raised, swollen, with blurring of the margins, and hemorrhages were noted. A baseline FBC was sent, which showed a white cell count of 6.33 with a macrocytic anemia of 5.6 and a moderate thrombocytopenia of 120 with 0.19 blast cells seen on the smear. Urea was 4.5 with a creatinine of 87 and a low calcium of 2.18. At that point, hematology lab had contacted the treating physician to say that they were concerned for a possible plasma cell dyscrasia. They had noted 7% plasma cells on smear. Viral screen for CMV, EBV, parvovirus, and hepatitis were all negative, and she had normal hematinics. So we sent off a serum-free light chain, which revealed a free lambda light chain of 257 with the reduced kappa lambda ratio. And serum protein electrophoresis showed a monoclonal band in the late gamma region measuring 67 grams per liter, with an IgG lambda noted on serum immunofixation. A peripheral flow sample was sent, peripheral blood flow sample, was sent, which was CD38, CD138 positive and showed 4.25% pathological plasma cells, which showed a lambda light chain restriction. So as Dr. Govender mentioned, she didn't have any high-risk cytogenetics. The matter was hypercellular and showed diffuse infiltration with plasma cells. She had no lytic lesions, and MRI brain showed no intracranial lesions or signs of raised intracranial pressure. She had a good ejection fraction of 66 and a normal abdominal ultrasound. So in summary, it was a 44-year-old female with plasma cell dyscrasia meeting the criteria for a primary cell leukemia, plasma cell leukemia complicated by anemia, thrombocytopenia, and clinical features of hyperviscosity. Factors that impacted her overall survival were that of low HB, low platelets, but she had no high-risk cytogenetics, lytic lesions, or extramedullary disease. She was RVD positive, virologically suppressed on treatments, and known hypertensive controlled with no known target organ damage. She was commenced on dexamethasone for 4 days, and lucky for her, tinnitus resolved and her vision slowly improved. She is then moved into our ward where she received 1 cycle of infusional CVAD and was discharged around day 10, where she went on to complete her oral cyclophosphamide and dexamethasone. In the interim, the motivation was sent for bortezomib and thalidomide as well as Zometa, which were all subsequently approved. And she's currently receiving her 4th cycle of VTD in our clinic with 2 doses of Zometa thus far. And unfortunately, due to the poor outcomes in this condition, an MDT held And the final decision was that she would not be for an autologous stem cell transplant. Thank you so much, and sorry again for the technical issues.
Thank you, Tennille. It's for your very good presentations. I think what we will do, Garrick, I noted your comments. I think we will discuss at the end. It's 5 minutes to 5, so I think I'll let Yadia go ahead. Thank you, Tennille. Yadia, you can share your screen.
Hi, Charlene, can you hear me? Hello?
Yes, I can. Yes, I can hear
Okay.
you. You can go ahead.
Okay, can you see my slides?
Yes, I can. You can share them though you on put them onto presenter mode.
Okay. Okay. Good afternoon, everybody. I'm going to be giving a short overview and update on the treatment options. Specifically, we're going to be looking at primary plasma cell leukemia today. So many years ago, the first case of plasma cell leukemia was described in a male patient, age 47, by Professor Gluzinski and his colleague. And this man presented with a palpable mass on his ribs, as well as rib fractures, splenomegaly, and a significant anemia. He was also found to have proteinaceous material in his urine, and the peripheral blood smear showed increase in plasma cells. At the time, he was treated with an arsenic-containing compound, and he demised 6 months later. We have since come a long way from treating plasma cell leukemia with arsenic. So today I'm going to be discussing where we are in terms of treatment options, and just to review some of the controversies around the new definition and how the biology of plasma cell leukemia differs from multiple myeloma. So plasma cell leukemia is the rarest yet most aggressive plasma cell disorder. And as Rita said, it was originally defined as an absolute plasma cell count of more than 2 in the peripheral blood and more than 20% of circulating plasma cells. The definition was later redefined to having either or criteria. We're now sitting with a criteria that says plasma cell leukemia can be diagnosed when 5% or more circulating abnormal plasma cells are seen in the peripheral blood. There are studies and literature to suggest that anything between 1 to 4% can also be considered and treated like plasma cell leukemia, because these patients were found to have an adverse prognosis and poor survival. A limitation of the current classification is that it does not consider plasma cell clonality strictly in the definition. And one has to always remember that a plasma cell population has to show light chain restriction. A reactive population, a very huge reactive population, can also be seen in polyclonal infections, inflammation, and even HIV. The classification of of plasma cell leukemia, is primary or secondary. Primary is makes up about 60 to 70% of cases, and secondary plasma cell leukemia makes up 40%. The numbers recently of secondary plasma cell leukemia have increased because patients being treated with multiple myeloma with novel and targeted therapies are living longer, and hence we're seeing more secondary cases. The numbers of patients in the literature are rather small, and we have limited data regarding the optimum treatment approaches in plasma cell leukemia patients. The prognosis of this disease has always been dismal, the overall survival being somewhere between 4 and 11 months. And currently, as it stands, it's quoted as 2 to 3 years. Whether that's a huge improvement or not, that's an opinion. I think this is still quite sad. So we have lots to do to try and improve the situation. And clinically, the patient presents at a median age of 61 years old, and will have high tumor burden evidenced by a high LDH, present with advanced stage disease and cytopenias, mostly an anemia and thrombocytopenia. Also, light chain and non-secretory subtypes are more common in primary plasma cell leukemia than in multiple myeloma, as well as increased in extramedullary presentations, which could either be the central nervous system or pleural effusions or the lung or the liver. And this is due to reduced expression of adhesion molecules like CD56, which impairs retention within the bone marrow. And that's why it's important at initial diagnosing and investigating your patient to do a PET CT if there is the suspicion of extramedullary involvement. Also, another difference between plasma cell leukemia and multiple myeloma is that lytic bone lesions are often less common in plasma cell leukemia. Also, their genetics is quite different. There's a lot more hypoploidy and IgH translocations, chromosome 1 abnormalities, 17p, TP53 mutations, and translocation 1114 in plasma cell leukemia versus myeloma. And whether or not the significance of the 1114 can suggest that in the future we might be able to use venetoclax in our algorithm, we'll have to wait and see. And the secondary events that occur commonly in plasma cell leukemia, MYC rearrangements. You often see a complex karyotype, high-risk cytogenetics, but decrease NRAS, KRAS, and BRAF signaling. The methylation patterns are also different. There's global hypomethylation in plasma cell leukemia, and gene expression profiling has shown that there's been silencing of the oncogenes, and the epigenetic mechanisms are more dysregulated in plasma cell leukemia. So in a recent article that was published in 2021 by Vistrom et al., he describes the major differences between plasma cell leukemia and multiple myeloma. And if you look at the top right-hand corner, he compares the characteristics between the both. And you can see that the median age of plasma cell leukemia is that they're younger, between 52 to 65. They have more anemia and thrombocytopenia at diagnosis. Bony lesions are less common, lots more extramedullary involvement, either lymphadenopathy, the liver, the spleen, the skin, the lung, and the CNS system, which we saw in our second patient that Tennille discussed with us, a very high LDH. And in typical multiple myeloma, LDH is not that high. In the peripheral blood, you should see circulating plasma cells of 5% or more. And definitely you will see a high infiltration of plasma cells in the bone marrow. In the bottom left corner, the table shows the cytogenetic aberrations, and Rita did touch on this, so I'm not going to go into it, but surprisingly, the translocation 1114 is very highly represented, as well as 17 P deletions. And in the bottom right-hand corner table, the author addresses a summary of the main clinical and laboratory features. And again, we can see in terms of plasma cell leukemia, light chain disease, and non-secretory disease is more common, and also cytopenias, anemia, and thrombocytopenia. So how do we treat plasma cell leukemia, primary plasma cell leukemia? So initially we want to immediately get disease control, and we might need to employ strategies like therapeutic apheresis to assist us with symptoms of hyperviscosity, which might include blurry vision or hearing loss or dizziness, epistaxis. And as Tennille's second patient had, she definitely had features of hyperviscosity. In plasma cell leukemia, there are mostly small studies that have been done, retrospective studies. And a lot of the data has been extrapolated from patients in multiple myeloma trials. So the literature is quite sparse, and plasma cell leukemia has often been an exclusion criteria in multiple myeloma trials. So what we know of how to treat plasma cell leukemia is largely based on how we treat multiple myeloma. And we see that again in the supportive care. So in terms of supportive care, one would also need to consider things like hydration, correct any electrolyte abnormalities. There could be a high calcium, support the patient with prophylaxis for antibiotic prophylaxis if there's any infections, and a pre-steroid phase, or a pulse of dexamethasone might help, especially with the CNS symptoms, until you can start your structured induction regimen. So what does the literature suggest for treatment of plasma cell leukemia? And it's induction with a proteasome inhibitor, bortezomib. Bortezomib is said to negate the adverse genetic features seen in plasma cell leukemia, together with an immunomodulatory agent such as lenalidomide. Next generation PIs can also be used, such as carfilzomib or ixazomib and other IMiDs, together with an anti-CD38 like daratumumab. In the interim analysis of this trial that I'm going to show you in the following slides, this also showed that the induction phase can be optimized by adding newer agents. So for transplant-eligible patients, induction therapy should be given until the best response is achieved. And we will see in later slides that achieving a complete remission after induction is one of the best predictors of overall survival. And for transplant-ineligible patients, one should aim for 8 to 12 cycles of induction, followed by maintenance. So in this study that was presented in ASH 2019, they looked at 2 groups of the population, a younger group aged 18 to 65 and an older group over 66. And for induction, they gave them 4 cycles of KRD, which is carfilzomib, lenalidomide, and dexamethasone. Then patients were harvested after 4 cycles, because remember, lenalidomide can affect your harvest. And then they went on to give high-dose melphalan and do an autologous transplant. They then consolidated the patients with 2 cycles of KRD, and then went on to do a reduced intensity, reduced conditioning allo transplant. So either it was with a sibling or matched unrelated donor, and then the patient went on to maintenance with a doublet. So lenalidomide plus carfilzomib, so a PI plus an IMiD. Okay, and in the elderly patients, what they did was they gave 8 cycles of KRD with maintenance of lenalidomide and cafalizumab, which is interesting that patients over 66 tolerated the cafalizumab, but they didn't note too many adverse events. But the results were quite good, and the KRD induced deep hematological responses after 4 cycles of therapy. So you can see 80% achieved a very good partial response and 33% achieved a complete remission. Toxicity of grade 3 and grade 4, they said was only seen mostly in the first cycle of induction and was manageable. And the conclusion was that KRD provides efficient and rapid disease control, which is essential to prevent early mortality because of the irreversible disease complications and to improve survival of patients with this aggressive disorder. So if you need to give rapid cytoreduction in a patient like Tennille's second patient, an ideal option or one of the options could be something like bortezomib, thalidomide dex, or lenalidomide dex with PACE or an anthracycline-based regimen, or hyper-CVAD. For frail, less patients you want to give less intensive chemo to, you could use bortezomib, len, dex, with liposomal doxorubicin or with cyclophosphamide. So here we are going to discuss whether we should be giving an autologous transplant or an allogeneic transplant to a patient with plasma cell leukemia. And I look forward to hearing your thoughts on this and what you're doing in your own practice, or whether you should be using a tandem approach and actually be doing an auto or an auto-allo. And you can tell me. So the trend toward superior overall survival in patients who underwent a tandem compared to a single auto transplant was better. And I'm going to show you a study that proves that. And this is possibly because intensity of treatment is more with a tandem transplant, and that's why they do better in the long term. So a tandem autologous transplant, or a tandem autologous transplant followed by a RIC allo stem cell transplant is recommended. And an allogenic stem cell transplant is a little bit controversial on its own, because whether you give reduced intensity conditioning or myeloablative conditioning becomes an issue, because initially you have high amounts of treatment-related mortality if you choose to give a myeloablative conditioning regimen. So in most of the studies, a RIC was given, but then there was a lack of overall survival noted with the allo transplants. And whether this was because of the higher treatment-related mortality, it's difficult to say. But if you are going to choose an allo, you should be offering it early. Remember, if you're going to do a RIC, you're going to do it at the expense of, higher chance of relapse. So that was the one downside of the allo. And then the other option is that you can do a high dose chemotherapy with an autologous transplant, followed by reduced intensity conditioning allo. So a tandem auto allo. And this will give you good cytoreduction as well as a graft versus myeloma effect. So in this study, we're going to look at some of the results that support this theory. And it's a retrospective analysis in 751 patients with plasma cell leukemia, and this is the largest retrospective study reporting on transplantation in plasma cell leukemia to date. And it looks at patients undergoing one of 4 transplant strategies. So either a single autologous transplant or an allogenic transplant first, or a combined tandem approach with an allogenic transplant following an auto transplant, or a tandem auto-auto. Okay, so 2 autos, one after the other. And the results are in the table below. So the total number of patients was 751. The median overall survival was 33 months. Median PFS was 14 months, and median follow-up was 48.8 months. So just to give you an idea, of the patients who had an allogenic transplant first, the greatest risk was in the first 100 days for overall survival and progression-free survival, and that was because of the high non-relapse mortality. Okay, and of the patients that had an auto-allo, so the tandem approach, there was no increased risk in the short term. There was significant benefit in PFS after 100 days versus a patient who had a single auto. And it was shown that it was superior in patients who did not achieve complete remission prior to the transplant. So that's quite significant. And in patients who had the tandem auto-auto, it was an effective option for patients who achieved complete remission prior to their transplant. So if we look at the studies a little bit deeper, these are the tables comparing the different characteristics between the patients who had the tandem auto-allo and those patients that had the allo first, and then all 4 strategies. And I just put this in for your own, for your information. But we can see in the graphs below that the patients who achieved complete remission, so for example, look at the green dashed lines. This is the tandem approach, tandem auto, who achieved CR, did really well compared to the others in terms of overall survival. And in terms of progression-free survival, also the tandem auto who achieved CR did very well, versus, for example, the tandem auto who didn't achieve a complete remission. So in essence, the results showed an auto-auto was an effective option for patients achieving complete remission prior to their first transplant, whereas in patients who did not achieve complete remission prior to the transplantation, their modeling predicted that an auto-allo was superior. This confirms the significant mortality risk within the first 100 days for allo first and suggests that tandem transplant strategies are superior. Disease status at the time of transplant does influence outcome. The limitations of the study was, however, that it did not include the induction and maintenance strategies. In general, without maintenance, these patients are going to have a short remission and early relapses. And single agent maintenance is insufficient in plasma cell leukemia. So one should consider at minimal a doublet. And it should be given until disease progression and not for fixed duration. And maintenance therapy after an allo transplant is controversial, but reasonable to offer while awaiting the full graft versus myeloma effect. And lenalidomide may potentiate the graft versus host disease, but it can be considered at lower doses, whereas bortezomib may decrease the graft versus host disease. So in terms of your relapsed refractory plasma cell leukemia patients, if you do have the option of enrolling them in a clinical trial, that would be great. But your decisions would be based on your prior therapy. So if you gave them bortezomib, Lendex in their first line, in their second line, you could probably use cafilizumab, Lendex, and salvage strategies with novel agents could also be included. And in terms of emerging therapies, we know that venetoclax is a possibility in patients with 11-14. So it might be included in the PI IMiD backbone. And NK cells with alotuzumab. Alotuzumab is a PI that targets SLAM7, and LEN followed by high-dose melphalan and an auto could also be an option. Selinexor for deletion 17p, but we know the side effects of that is quite bad. And then there's the panobinostat and gemcitabine, which are also of interest. So this is my last slide, and I just wanted to highlight the algorithm one should consider when one is treating a patient with plasma cell leukemia. If you have 5% or more plasma cells, decide, is your patient transplant fit or transplant unfit? If he or she is transplant fit, induce them with a triplet, either bortezomib, lendex, or carfilzomib. Or if you want to rapidly cytoreduce them because they have extramedullary disease, very aggressive disease, high LDH, hyperviscosity, then you can use something like RVD with PACE or hyper-CVAD, cytoreduce them, give them supportive management, and possibly apheresis if they have hyperviscosity symptoms. You can then go on to autologous transplant if they're in CR, and then consolidate with a PI and an IMiD, a doublet or a triplet, followed by maintenance until disease progression or until unaccepted side effects. If a donor is available, if a suitable donor is available, you could either do a tandem auto and reduced intensity allo, and then maintain with a doublet, or you can go straight on to a myeloablative allo. And if you're going to choose that option, you should do it early and upfront. And if your patient is transplant ineligible, induce with a triplet. If you need rapid induction, you would use cyclophosphamide, possibly a better agent in the more frail population, and then consolidate with a doublet or a triplet, and then maintenance until progression or the side effects cannot be tolerated any longer. Thank you.
Thanks, Yadia. It was a really good overview, and thanks for going through it despite you being ill. So Yadia has a terrible cold, so if you didn't notice that with her speech, but she managed to get through it. So thank you, Yadia. There's not many questions in the chat group, but I just wanted just two things that Garrick had mentioned. He said, interesting to see the varied morphology of plasma cell. Do you know if morphological variant in the article from Hussein et al. Correlated with the nature of the disease, that is aggressive versus indolent? I know anaplastic in any sense, the word is more aggressive. And Rita said, anaplastic morphology was the focus, no comment on any clinical feature. And then Shrita went on to say, it seems that plasma cells can indeed be very creative in presentation. A colleague of mine presented a case, purported myeloproliferative features for a short while ago on this platform, turned out to be a myeloma masquerading as MPN. Yeah, and then Garrick also asked about how we accessed ixazomib. So this was the time when Takeda hadn't yet registered ixazomib, and we were able to access it on a compassionate basis. So that's what we actually used on the first patient. So before, I just wanted to make a comment, just my experience. So I must a disclaimer that I'm no expert on plasma cell leukemia. The reason we decided to present these cases is that it is very rare, and we don't often see them. But my experience by the time I actually started training as a clinical hematologist, interestingly, the patients that I had seen were actually young African female patients who were HIV positive, and they were in the age range from about 30 to 50. So that was my experience with plasma cell leukemia patient. And the first case that Tennille actually presented, this patient actually had a good quality of life for at least 8 months to a year, if I remember correctly. So using the oral medication, which was ixazomib, cyclo, and dex, we actually got a relatively good quality of life for a while. And unfortunately, that was the most we could do for her. And so, yeah, that was the sad bit about these patients, that they are young and majority were HIV positive. And then in my time, I've seen a few that were secondary plasma cell leukemias from patients that were actually known with myeloma. So I don't know if anybody else wants to comment. I don't see any other questions. I don't know if Estelle or anybody else with experience may want to comment. This was just, I remember now, there was a Free State University actually also published some interesting cases about HIV positive primary plasma cell leukemia some years ago. So I think, I don't know if Jock's on the call, but I think they've also had experience with sort of the similar sort of population of patients.
Charlene, I don't know if there are others from my unit here, but
Yeah.
we actually haven't seen many of these lately, strangely enough.
Yeah.
We don't see the young HIV positive women so much. It's more, youngish men, but we also see women. And I must say, I suppose from our side, it's been something that we simply did not have these combinations and could not think of using them. So I do think what I want to say, I want to commend you guys. It was brilliant. I've learned a lot. Thank you, Rita. Thank you, Tennille, and thanks, Yadia. I've learned a lot of the potential of treating it. Very, very well presented, and it's definitely now going to be something that I know I'm updated up to the newest and the latest. So very well done.
Thank you, Estelle.
I can assure you, in private practice, these patients will, this will be extremely important, and this is exactly what people will do. So it would actually be interesting in South Africa to hear what their experience is when they really throw everything at it. That would be very, very nice. I think we must get those answers from our colleagues. Yeah.
Estelle, this, what you say is so true, because the first case that we had discussed was, fortunately, we were able to get a donation program. So we were able to persist on with this ixazomib until this patient actually had, a little MRD, and she had become her viral load had become suppressed. And, so I think if we had access to more resources and more experience, perhaps, our outcomes may be better, but we obviously don't have that in our setting. But the lady that I speak about, she said she actually had such a wonderful quality of life in that 1 year. And she was, doing everything that a normal person would do despite being on dialysis. And yeah, so, I mean, it was her good fortune that she was able to actually get access to the ixazomib at that point. The other patient that we are currently treating, we obviously still early days, so we will see how what happens with her. And
yes,
so
feedback.
yes,
I think the first one did very, very well, and that is true.
The one case I remembered when I started training was that she was a teacher from the South Coast, and as you said, we didn't have access to much at that time. And I remember that we treated her with VAD, and she as well survived for a good 8 months or so before she died. But I mean, obviously, this is it is a grim prognosis without access to good agents. So, but with that, I think I've been rambling on a bit. Nobody else has any questions. I just wanted to thank the NHLS team for sharing some of the slides with us, um, and again to Rita and Tennille and Yavia for putting all this effort, and we will see you all next week. Please don't forget to complete the survey at the end, and have a good evening, everybody. Bye.
Good evening, everybody.